Hi, everyone. I'm Craig Norman and am the host for tonight's event sponsored by Euclid Systems Corporation, the maker of Euclid Emerald and Euclid Max spherical and toric lenses for orthokeratology. Welcome to all of you for watching. We're looking forward to a really interesting interview this evening. As a reminder, the opinions voiced during this program are purely mine and my guest, and not necessarily those of Euclid Systems. Also, if you would, please write any questions you may have while watching in the comments box, and we'll respond as well as we can during this presentation. Tonight's discussion is with Dr. Azinda Morrow regarding her methods for determining what the best myopia management option is for each individual patient, and importantly, their families. With multiple alternatives available today, we're going to ask Dr. Morrow to describe when and how she determines if Ortho-K, soft lens multifocals, atropine, or a combination therapy is indicated. And additionally, we hope she will provide us with some tips on how to communicate this choice to young children and their parents. Dr. Morrow is an assistant clinical professor at the SUNY College of Optometry, University Eye Center, and is responsible for clinical supervision of students and residents in both cornea contact lens and the myopia management clinics, which, by the way, she left like 10 minutes ago. She earned her Doctor of Optometry degree from SUNY in 2017 and completed a residency in cornea and contact lenses at ICO in Chicago in 2018. In addition to her clinical responsibilities, she teaches in the contact lens preclinical laboratories and engages in clinical research through the Clinical Vision Research Center, where she's been both an investigator and sub-investigator on multiple contact lens and myopia control studies. Dr. Azinda Morrow, welcome. How are you doing?
I'm great. Thanks so much for having me, and thanks for the intro.
Oh, what a pleasure to have you here. We know that you have some unique experiences where you're located right now at SUNY and in the myopia control clinic and working with the residents, and most importantly, working with patients. And we really hope that you're going to be able to share at least a little bit of that wealth of knowledge that you have with the audience this evening. So to begin with, we know that you're in an academic setting, but can you explain in a little more detail exactly what that means? And are you only in one facility, or do you work in more than one facility?
So for any of you who've visited SUNY, we are like a one building machine. So, we take up this space in Midtown Manhattan, and it's this huge 18 plus floor building. So all of our student activities occur there. So lecture halls are present there, but all of our clinics separated by specialty are also all in the same building. So it's a really unique model that is really convenient because it's so easy to access, but also I always think of it kind of like a black hole. Like once I go in, everything I do happens there, and then somehow I'm finished. And at the end of the day, I get to leave. But it's nice that we have everything all included. But as you mentioned, my responsibilities kind of vary. So some teaching responsibility, clinical responsibility, and research responsibility. But all of that, ties in my background of specialty lenses and love of myopia management. So it's a really fun place to be. So I'll take the black hole.
Yeah, that's really interesting. I've had the fortune of visiting the school, a number of times. First of all, I'm always amazed. Here you are right in Manhattan in some of the primo property in the world, and there's an optometry school. And so that's something. The park right across the street is pretty cool as well. As a place to kind of break away at lunchtime or whatever, especially when the weather is nice. And then I think I've shared this with you before. I was also amazed that going in there, the security of going in that place was unbelievable. It is terrific, right? But it was really set up to make sure that you can monitor people coming in and out of the building, as you would expect in any large downtown community. I wonder, and this is totally off topic, if ever the subject comes up at SUNY, whether or not they should sell that property and be able to build like their own campus somewhere with the money that it could actually be able to sell for.
Yeah, it's interesting because yeah, I mean, truly, like I cannot even imagine how much it costs to like live or like to, house the whole school here. But I mean, I think it's a huge plus that we are here. Our patients come from all over. So we have patients who, come from all 5 boroughs. We have patients who come from, Connecticut, some from North Carolina, some from Florida, New Jersey. And so, like, the accessibility of having the clinic here, I think, is a huge plus in a way that we get a huge diverse patient population that if we did sell and go somewhere else, I think it'd be hard to meet the needs of a lot of our community here.
Sure.
So,
Well, with the subway system and being so close that, I mean, it's easy to draw people from, that live
all over.
45 minutes away, but it's such
Mhm.
easy way to be able to get there. So you see patients from all over. I know in particular, the last time that I was visiting there, now this is pre-COVID, but I think right before COVID, I mean, I still can picture there was this big flagging poster or sign introducing the myopia control clinic in the lobby. And of
Mhm.
course, the lobby is big and, high ceilings. So this flag or whatever, however that poster was made, it stuck out because of the size of it. And so that promotion, is really terrific in the lobby like that of any optometry school. I haven't seen anything like that before.
Yeah, definitely. I think because, like I said, some of our patients come in and they go to, let's say, the pediatrics clinic or the primary care clinic. They go to the lobby, they get sent up to a certain floor, and they see those things only, right? But
Right.
they have family members, they have friends. And so it really is important. I think, obviously from a clinical standpoint, but I would say, like putting my research center hat on, it's really helpful to recruit subjects for different studies that, they wouldn't have stopped off at our research floor to find out about if it hadn't been for those screens. Yeah.
Right. Right. Okay. So to build upon that, so that uh, you have a specialty lens background, of course, and is there a specialty lens clinic in the facility? And then if so, is myopia part of that clinic or is it separate?
So it's interesting because I think originally our myopia clinic came about from Dr. Catherine Richdale, who's at Houston now, and she had a specialty lens background. And so it was kind of enveloped in our cornea contact lens department for a long time. And so I think for that reason, the people or the doctors who were asked to be members of the myopia clinic, like myself, we had specialty lens backgrounds, and that's kind of how who staffed the clinic. But then very recently, right before COVID, we had our grand reveal of our pediatrics clinic here, which was like brand new, remodeled, newly renovated, beautiful rainbow colored clinic for these kids. And so at that point, we actually shifted from being under the cornea contact lens department to our pediatrics department. And since then, we've added, a pediatrics background doctor to our service. And so it's nice that we're kind of marrying the two backgrounds together now.
Right.
But yeah, for a long time, it was specialty lens doctors like myself.
Okay. So like many large facilities, whether they be an optometry teaching facility or whether it be a large multi-specialty practice, that there may be more than one person, more than one doctor that interacts with the patient. So is there a protocol that is generally followed so that the workup is the same, kind of the options are presented similar? What I'm really driving to is how do you, form that decision tree when you're trying to decide what is the best for a child and their parents and their family? And how much different is that if I was seeing them versus you were seeing them?
Yeah, it's a great question because it's so true. Like so many of our patients are like, oh, I haven't met you before, but they've like met every other doctor in
Right,
the service,
right.
right? more so in the contact lens department, but even in our myopia management clinic, I think, one thing that we rely heavily on is a written protocol, like you were mentioning. So it is really nice. And I think it's surprising for students and residents and visitors who come that, when they're like, oh, tell me about the flow of your clinic, I usually like hand them this written out piece of paper, which if you think about many of our other clinics, we operate very much like, don't follow a protocol, like, the art of the exam. And I
The
think that
intuition, right? Follow your
yeah,
intuition, right?
right, which like still is important, but I think that our clinic in the myopia management service is very much, I would say it has like a heavy research kind of element there, that we really rely on making sure that we follow this protocol so that despite whatever doctor comes to see the patient that day, we're following a written protocol. Also helps for consistency and better data tracking, and deciding if we're going to alter treatment or keep treatment the same or whatever. So I think that having a written protocol for a myopia service is really helpful, especially in a setting like mine.
Right. And you can understand, for instance, the pediatric team, their heads might be more wrapped around atropine as the first place to go, right? And somebody from a specialty contact lens practice like yours, you might be thinking Ortho-K first because you're a contact lens person and you want to manipulate the lens. And so the protocol kind of takes that away, I'm sensing, and allows everybody to start at the same spot and hopefully end up near the end result.
Yeah, it's interesting you mentioned like the peds perspective being more atropine based, because that was something that was kind of actually happening, and kind of like a growing pain that we had when we started the myopia clinic, because a lot of patients who were being managed in peds, because a lot of our peds doctors were super comfortable managing with atropine and weren't dabbling in the contact lens part of it. And then their patients would progress. And then with the onset of the clinic, they were like, hey, like, why don't you go to myopia management and, they'll take it from here. And, we did things totally differently. We saw them a totally different like follow-up schedule. And so for a lot of the patients' families and a lot of us, it was kind of like this growing pain, because we do kind of have this different managing style. But again, now that we have this protocol, at least for those of us in the service, it really does help a lot. But I will say, like, I'll admit, like, the bias of my specialty lens background definitely comes through in offering treatment options to our patients. I think that the good news is, and the good thing is that like all of us in the service are comfortable with each one. And the thing that we have going for us is that like they pretty much work the same efficacy. And so I could kind of be like, well, like I would pick a contact lens if, the patient's parent would say like, what would you pick? Right. But I think that, we have a lot of options for our patients and are all willing to do whatever option works best for that family.
Right. So as you're discussing it with the family, because this is a family endeavor, it's not the child. And in fact,
Totally.
the child is probably the last person in the family that wants to be. Yeah. And so when you're doing that, and as you just stated, that the efficacy of the three categories that we just discussed, soft lens, Ortho-K, atropine, is similar, right? Spectacles coming down the path seems to be falling in something similar, maybe less on some reports, maybe a little more in others, but similar. So it does really move it from an ocular issue to a lifestyle issue more than anything. Like, what does the child want? But again, of course, the parents will overrule that in general. And then what fits best for the parents. Is there materials that you use to help walk through the family when they're being explained this? And in particular, I'm thinking about, and I don't know what the status is right now at the school, but in the time of COVID, it's only allowing like one parent into the exam lane. I don't know if you did that or don't do that. And then that parent has to go back and explain it to the rest of the family. So when you're walking them through the lifestyle choices, Is it all verbal, or do you have stuff that you hand out to them that helps walk them through this?
Yeah, so we do a little bit of both. So we do have a specific, like what we call a consultation visit, is the first visit that any of our families and patients get in our clinic. But at that point, we just determine what they're eligible for. And at that point, we do discuss, pros and cons of each of the modalities. And, I think it's really interesting because as, I try to tell the students and try to tell the residents, every one of those consultations can go completely differently, right? Like some of the parents, like as soon as I sit down, I'm like, there's contact lenses and there's an eye drop, and they're like, no contact lenses. Or
Right.
like conversely, they're like, no eye drops at all, right? So some of them are really lengthy because they're interested in everything and want to hear more of our opinion. But, we do try to go over it as best as possible. And like you have alluded to, it's really a lot more of a lifestyle. So I feel like everyone who works with me, I think, is sick of me saying this, but I'm always like, if I cloned your child and, had this, a different family in a different room, but the data, refractive error, axial length, everything was the same, like maybe they would pick something completely different, and that's totally fine, and it may work just as well. And I always try to emphasize that it really is a lifestyle choice. I think that that's super important. But we also do give some written materials to our families as well. So usually I use our conversation to kind of guide which materials I'll give out. So, if they're just like off the bat, yeah, I'm interested in contact lenses, but I don't want to do that eye drop. We have like a frequently asked question sheet for each modality, and I'll give out the ones that they're still considering. So that could be all of them, that could be one of them, just so that they, make sure that that's really what they want to do. And I think one thing that is just the reality as well is that fees obviously come into play as well. So we do have a fee sheet that we provide at that visit too, because of a lot of our families, the affordability can be different. So that makes their decision. Although obviously we present all the options as if it wasn't an issue.
Right, of course. Are you finding that today that the families that are coming to the myopia management clinic are better educated than they were like 2 years ago or 3 years ago on what the options are before they ever get to the office? Or are you still running into a lot of the families that are saying, hey, my kid is nearsighted, I don't want him to become nearsighted like me, what can we do?
That's a really interesting question. I think that it's funny because I think, kind of going back to that, the fact that we have patients from all over and all different backgrounds and things, like I am really surprised by some of the patients who come in, and they're like, I want the FDA approved multifocal, contact lens. And I'm like, wow, like, some people, we really have to like go into the detail and talk about what the options are, and they're not as sure. And then some people come in and they already know, or like they say, hey, my kid's friend wears Ortho-K or whatever. So I think that it is surprising how much people do know now. And, I think that's one kind of, I guess, bias that I have in the clinical setting that I'm in, because all of our patients are referred, right? So like if I was in a primary care setting, identifying these myopic or pre-myopic children who I was thinking of, managing in a myopia management style, I think that would yield for more like, hey, this is what myopia is. Here are the reasons why we need to manage it. Here are the complications that can occur later on. But most of our patients and families have had a little bit of that, at least, because of our referral style.
Okay, so that's an important point. So that generally speaking, the child in this case for myopia management and their family, they're not referred in directly to the myopia management clinic. They're coming through primary care or pediatrics first, or can they end up directly in the myopia management clinic?
So it's a little bit of everything. So some of our primary care doctors are referring, a lot of our pediatrics doctors are referring. But then we do have outside doctors who know that we offer the myopia management service. And so we do get some new patients to our clinic where the first time they come is to our clinic too.
Okay, great. I would like to remind all of our viewers, if they do have any questions that they'd like to ask of Dr. Morrow, to please type them into the comments box and we will try to get to them. So we've chatted about communicating with the parents and making the decision on lifestyle. And it's really cool the way that this protocol is being utilized in your facility. I have one additional protocol discussion. Do you review that periodically and say, hey, maybe we should change this a little bit and I don't feel so comfortable presenting it this way?
Yes, that's definitely something that, just like, we were chatting a little bit about before the webinar started, but talking about how myopia is really moving at a fast pace. And truly, I feel like every day there's a new study or,
Sure.
a new finding that is tailored or like changing how we treat our patients. And so that is definitely an active document that we review. Um, the other thing to consider is that we are lucky enough to be at an academic institution where we are given different kinds of imaging or diagnostic equipment. And so for that reason, maybe we'll get a new topographer and now we need to incorporate that into our
Of course.
protocol. So it is definitely something that we visit often. But a lot of it, like I said, is based in kind of like a research style. So I find that, when I go to the research clinic, the flow is very similar, testing is similar. So that's kind of something that actually, if I think, 3 out of our 4 doctors in the myopia service are also in the research center. And so that kind of has a nice marriage that,
Sure.
we kind of can see it from both perspectives.
Yeah. Yeah, that actually is terrific, because I think you definitely approach it a little differently as straight clinician versus clinician researcher when you're looking at certain things. So when you're talking to the parents, and I know how it is in the exam lane, everything goes to usually mom, and that's the focus. But do you have any special way that you actually communicate with the child so that you can bond with the child somehow and make them be a believer in you as well as the parent?
Yeah, I think that's so important. It's first of all, it's really awkward to like talk about someone when they're sitting right
Sure,
there, right? They're trying
sure.
to listen and comprehend everything too, even though, they may not be the one pulling out their wallet or like, having to make the decision of can we travel this far this many times or whatever. So I always try to bond with the kids. And I think that, one thing is that because it's such a lifestyle choice, I always try to ask the kid based on what the parents were saying, like if they feel on board or if they're kind of hesitant or whatever. So, one thing is, sometimes kids are really afraid to wear contact lenses, for example. And so when the parents are like, I don't want to do the drop, definitely want to do contacts, at that point, I always look at the child and I'm like, hey, like, are you excited about wearing contacts? Is that something that you want to do? Do you have friends who wear contacts?
Yeah,
That kind of thing. And one thing that for me personally, so I am an Ortho-K wearer myself. So I think that that's something that I always try to share with the kids, especially if their parents are leaning towards Ortho-K, is I tell them like, hey, I wear it, like I have nothing on right now. And it's so, it's clear and I don't have to, have anything in my eye all day. And I think that that's one way that I really try to bond with the kids. Because I think that that's important for sure.
right,
Because this is like a marriage of years of care, right? You're going to see these kids grow up. You
right,
want to be their friend first.
right. Well, there's no doubt if things work out, it's the 10 to 30-year plan somewhere in there that you'll be seeing these folks. So that's great, because I think it's so important in the exam lane to bond with the child, and they're going to have enough rough days as they're trying to figure out what to do because
Yeah,
their own lifestyles being disrupted. And I always found that building that bond with the child was also quite rewarding as well over
totally.
time. So can you talk a little bit, that as a specialty contact lens fitter, we know you like to fit technical like designs and stuff. Can you talk about how you position Ortho-K and discuss kind of how that works when you're describing it to the patient and the parent combined? And is there some little tip that you have that makes that explanation process go easier?
Yeah, I think that, you know, because Ortho-K is so customizable, I think that people really, parents and kids, like really pick up on that fact. So they're really excited about the fact that I always say, like this lens wouldn't exist if I didn't order it for you, right? Like I'm going to get this lens for you. It's only going to be made for you and no one else versus, other lens options that we can just pull off a shelf, right? So I think that the customizability piece of it, people really are excited about. And I think one thing too is, I really do form such a great bond with most, like all of my Ortho-K patients because we see each other so often. So I usually say, like we are in this together. So if there's any issue, like you need to call me, and like we're going to be keeping each other informed a lot, especially at the beginning. And I think that, kind of to what we were talking about before, that the families and, patients really like the fact that like we are going to be a team from now on. So kind of similar to, patients with irregular cornea that I'm fitting, like I'm like, hey, I'm going to see you quite a lot in the next
Right.
few months, right? And I think that that kind of connection with the doctors, that's really rare in a lot of areas in medicine. And I think that even in optometry, like vision therapy would be similar in the sense that you like get these real bonds. And not to say you can't bond with your patients that you see every year. I definitely have some of my favorites of those, but it really is a special relationship to have to fit a patient in Ortho-K.
Yeah.
On both sides.
For me, I always would even expand that. Specialty contact lenses are really a bonding effect between the practitioner and the patient because they are different. Their situations are unique. The products, to your point, are customized. And when they live up to their promise and work the way that you want them to work, it's a terrific kind of thing to have happen. Now, when you're
so
seeing
rewarding.
these kids, for sure. So you see the child and you fit the lens by whatever method that you use. You get the lens to dispense it. Are you a proponent of seeing them after the first night the next day, or do you like to wait a few days or a week for that first visit?
So it's funny, I was talking to someone else about this exact question earlier today. We do see the patient after the first night of wear, and I always, usually at that consultation visit, or definitely before they decide to go for Ortho-K for sure, I always say like, I'm going to have to see you once in the morning, just like prep that in your mind that that's going to happen. So we do a 1-day follow-up. I think that a question that I get asked a lot from students and residents is, do you come in, I remember being taught that we have the patients come in wearing the lens after the first night. And personally, I don't do that, mainly because of the fact that like, even for me, and I come here every day, it takes me 35 minutes to get to work on the train. And, it's like kind of hectic. So I always tell my families, I'm like, you don't have to wear it in on the first day because some of them come from quite far. But we do a 1-day check, mainly from a health perspective, and also just to make sure, things are trending in the right direction. But their topography, that they actually wore the lens the night before. There's lots of secrets that can be revealed that sometimes the parents don't even know about. So we do that here. It's tough because obviously scheduling can be difficult with a 1-day follow-up, especially if you want it in the morning, if a provider is available or not available, if another one is available. So that part can be a little tricky. But like I said, I think a lot of this and with any patient care, like really comes down to good communication. And so I always make sure that my parents and families are aware, like one day we will see each other in the morning.
Right. Well, it's interesting. Having lived through the whole modern Ortho-K world myself, it went from 100% of the time you saw the patient wearing the lenses the next morning. And now it's kind of switched in the other direction, that if you are seeing them in the next morning, you don't care if the lenses are on or not, right? So that switch has been interesting to me, because my opinion was I wanted to see those lenses on their eye that next morning because I may never see lenses on their eyes again.
Fair.
And that was, and that's what was my rationale. I think it's probably wrong, but I thought it was the right thing because of that. But now just understanding, it's much more important to see what's happening to the cornea, not the lens, how it's fitting, but we can tell by the cornea itself. So as we get ready to start to wrap things up, I do have one other question. We're in the era right now where we're using a much larger percentage of toric lenses, toric periphery designs to, better position lenses on the eyes, trying to make sure we get a better seal 360 degrees and so on. And so when you're working with your patients and their families and you are deciding to fit them with a toric lens, do you explain they need a toric lens, or do you just fit the lens and not spend any extra time talking about what's different about that versus a spherical lens?
I don't spend too much time talking about it. The only time that I really will go into it a little bit more, because one, I think most people, when I say like, I'm going to build you a custom lens, they're like, cool, the doc's got it, like they'll figure it out. But I think that the times that I do mention it are more when they're like borderline, or I'm like worried about how lengthy the fit will be. Because some of these spherical corneas, right, it's just like lens one, done. And it makes life on everyone's side like super easy. But it's like when I have to say, like, I need to see you back again. We need to try a new lens. We need to, order this new one, try it out. Let me see you again. And like we have that kind of follow-up schedule where it is a little bit less straightforward of a fit. I think that's when I usually mention like, hey, things are going to be a little bit trickier. So we're going to expect to see each other more often. We're going to expect that maybe the first lens isn't going to be perfect, but it'll maybe get us, 85% of the way there or whatever. And I think that those are the times that I take the time to explain it a little bit more. Do I go into like the lens design part of it? Not too much.
Right. Yeah, I think that's an excellent strategy myself. I've thought a lot about this on, you've already told them you're going to make a special lens for them. And then you don't necessarily have to tell them again. It's really, really special for them because you are customizing it, directly for their eye. So that's a really good tip, I think, as well. So as we get ready to close, do you have anything else you'd like to say to our audience relative to the management of children and their parents in Ortho-K or other myopia management systems?
Yeah, I think that, and we've kind of touched upon this a bunch of times, but I really think like being on the same team, good communication with your families and your patient, it's so helpful because like I said, if you do have a tricky fit, they're expecting it, right? They're not like, hey, but why was it so much faster for my neighbor's kid,
Right.
So I think that, as long as everyone is willing and excited, excitement being a huge piece of it, right? We want everyone to be really excited about what we're going to pursue together over the next few years. And communicating that effectively, I think, is just so helpful. But I think, again, like to what we were talking about before, like it makes it so much more rewarding, right? Because we're not strangers, we are a team and we're excited and we're going forward with this treatment modality, whatever it may be. I really think that that's what is successful for any doctor, but just throwing the myopia spin on it, it's like every day is a new day. A new lens might be available tomorrow. Like I don't know. It's just like it's an exciting place to be in clinical care, and I truly enjoy it. Like, don't tell my contact lens patients, but myopia is definitely my favorite clinic by far. It's just so fun to be with the kids and really change lives. It's so rewarding for everyone.
Right. Well, you're doing a great job, and
Thanks.
your ability to communicate with the patients is only superseded by your ability to communicate with us and our audience here tonight.
Oh, thanks.
It's really been a pleasure to be able to have you here. Keep up the great work. What you and the team is doing there at SUNY is fantastic. And I think your patients, excuse me, and their families are going to be happy for years to come. maybe we'll revisit this in a year and we can talk about something totally different, to your point, that is not available today, and something else you're using as far as either designs, products, systems, whatever they might be. So Dr. Azinda Morrow, thank you so much for participating in this Euclid Systems Corporation event. Everybody involved is greatly appreciative. And to our audience, thank you so much as well for spending some of your valuable time watching us. Goodbye.
Thank you so much. Good night, everyone.